Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hey everyone, good afternoon. It's Susan Coffin. I'm here for Attitude Magazine's weekly ADHD Experts broadcast. Today we are honored to be talking with pediatricians and authors, Dr. Eileen Costello and Dr. Perri Klass, about managing anxiety in children and adolescents with ADHD and with learning disabilities. They will be telling us more about the prevalence of anxiety in kids with ADHD and learning differences, about how the symptoms of a primary anxiety disorder overlap and are quite distinct from the symptoms of ADHD, why cognitive behavior therapy, or CBT, is the gold standard for treatment of anxiety, and some advice about developing language in your family to help kids understand and talk about their anxiety. We are really pleased to welcome these two distinguished speakers. I want to introduce them to you first. Dr. Eileen Costello is a clinical professor of pediatrics at the Boston University School of Medicine and the chief of ambulatory pediatrics at Boston Medical Center. She and Dr. Klass are the co-authors of a great book, which I recommend to all of you, Quirky Kids, Understanding and Helping Your Child Who Doesn't Fit In. It was published by Ballantine in 2003. It's still a great book, even though that was some years ago, and they are actually working on a new edition with an expected publication in 2020. Dr. Perri Klass is someone you may know and read in the New York Times. She's professor of pediatrics and journalism at New York University, and she writes regularly on topics of relevance to children and families, including a weekly column called The Checkup in the New York Times. She teaches pediatric residents in the primary care program at Bellevue Hospital in New York and is the national medical director of Reach Out and Read. So don't miss Dr. Klass and Dr. Costello's book, Quirky Kids, Understanding and Helping Your Child Who Doesn't Fit In. They do a great job of discussing the range of our children and without putting them in sort of two specific buckets. Thank you both so much for joining us today. I'd like to also thank the sponsor of this week's webinar. As you all know, our sponsors help us fund these webinars, which we provide at no cost, and we are grateful to them. And our sponsor today is NEBA Health. NEBA Health offers the first FDA-cleared brainwave test to help clinicians determine if a child's symptoms are due to ADHD or to some other condition. NEBA is only available by prescription. It's a non-invasive test. It takes minutes, and you can find a NEBA provider in your area on nebahealth.com. That's NEBA health.com. So thank you to NEBA Health. Before we start, let me just tell you a bit about how this will work. As you know, Dr. Costello and Klass will present their slides, and then they'll take as many questions as time permits. Before the presentation begins, we want to just ask you what your primary reason for listening in today is. You'll see a survey on your screen as to whether you have ADHD, you're here as a caregiver or a teacher. While you take that, let me just talk you through a bit the webinar console that you'll see on your screen. You'll be entering your questions in the Ask a Question section of the screen. You can download the slides now if you wish by clicking the Download the Webinar Slides in the Event Resources section of the screen. Some people like to take notes. To learn more about today's sponsor, about NEBA, or about the expert speakers, please click the tabs just above the slides. If you have audio issues, please close your browser tabs if they are open, and preferably use a wired internet connection. It's usually a slow internet speed that causes problems with audio. So that's the key to that one. Let's take a look at the survey and see. Okay, 64% of you are caregivers, not surprising. As usual, welcome. And with that, let me turn it over to our speakers with our thanks as usual.
Thank you so much for having us. This is Eileen Costello from Boston University. Perri and I are old friends and colleagues from training, and have worked together for many years in a primary care practice in Boston, where we developed an interest in kids with atypical development or with learning differences or ADHD, ADD, ADHD. And so this is a topic that's near and dear to us. And even after 30 years of practice, I'm constantly learning new things about what it means to take care of kids and to really understand their experience and the experience of their parents.
Hi, this is Perri Klass. I'm from New York University. As Dr. Costello said, we're old friends and colleagues. We've been talking about the interesting children and complicated families who come into our exam rooms for many years. And when we decided to write the book that you heard about, Quirky Kids, what we wanted to focus on were very specifically what gets in the way for children, what gets in the way for families, what makes it hard to get through the morning, what makes it hard to get through the school day, what makes it hard to get through the vacation. So thinking about questions like anxiety, it was sort of a natural way to say what's getting in the way and what can families and the people who they look to for help do to make this easier on their children.
Let's just start with at the very beginning. So I think it's worth talking about what do clinicians think of when they think of anxiety and in childhood. And some degree of anxiety is normal, right? You expect infants, at 9 months of age to have stranger anxiety. When I walk into an exam room with an infant on her mother's lap, if she's 4 months old, she's thrilled for me to pick her up and smile and bounce her up and down. If she's 9 months old, she wants no part of me. That's normal. That's typical. We expect that. The sort of things that kids will worry about as young children, like they're afraid of monsters, they're afraid of the dark, they're afraid of hurricanes or natural disasters, some degree of social anxiety in teenagers, like all of that is sort of is normal, sort of developmental. It becomes a clinical concern when the fear or the worry is severe, when it's not appropriate for the stage of development. So if a 12-year-old is still afraid of the dark, that's not typical. Or it takes up too much space in the child's mind. It's causing them to perseverate about something when they ought to be thinking about other things. Or it's making it difficult for them to, for example, access the curriculum at school or engage with their peers. Then it becomes a level, a level that we would call a clinical anxiety disorder. We know, and all of you that are listening to this know, probably better than we do, that anxiety is much more common in children with developmental differences like kids on the spectrum and in kids with ADD, ADHD, and learning differences. Anything that makes a child feel different than their peers is going to create anxiety. And not being able to learn the way the other kids learn, not being able to focus and pay attention, not understanding the social cues, all of that will create anxiety over time. We're going to go through the list of the different types of a real, bona fide anxiety disorder in children, and it's worth saying that one child may experience more than one type of anxiety, either at the same time or over their lifetime. Some sorts of anxiety tend to get better, and some of them kind of morph into another type of anxiety. It's an enormous problem in the adult population as well as in childhood. Most adults report that their symptoms started when they were kids. I'm moving on to the next slide, which is sort of about the major types of childhood anxiety, and I'll go through these pretty quickly because I'm sure that a lot of this audience is pretty educated and has heard all of this before. A generalized anxiety disorder is sort of just a generally anxious child who's worried about all sorts of things, about how things are going at school, their family, are they going to get hurt, is somebody going to die, is there going to be are we going to get bombed, kind of just general feeling of doom that, things are out of my control and I can't stop thinking about them. Kids with social anxiety have a severe, like more than the rest of us, a kind of severe anxiety about being embarrassed in public. And so, all of us have that to some degree. Your slip is hanging or you have food on your teeth or, none of us like to be in those situations, but a true social anxiety disorder is when it's sort of paralyzing, that you are so anxious about playing the piano in front of your friends that you might make a mistake, that you can't do it, that it paralyzes you. Separation anxiety, we talked about earlier, is quite common in the very young child, but we definitely see it in older children, kids who are afraid to go to school because they can't separate from their parents. Sometimes they're just afraid to be independent of their parents, and sometimes they're worried about something happening to their parents while they're not there. And I think these are the kinds of things that need to be figured out by an expert. Phobias. I just saw an 11-year-old boy last week whose mother was about to take him on a trip on an airplane, but he has terrible fear of airplanes, elevators. My office is on the 6th floor, and he always takes the stairs because he can't get into an elevator. So he is, kind of claustrophobic. And unfortunately, they were about to go on this trip, so we can talk about that later. But that he's got many phobias, but those ones about being in an enclosed space are very real. Panic disorder, I think everybody knows what a panic attack looks like, but I think the thing that is surprising to people is they can be totally unexpected and occur, either in association with something that creates panic or not. Sometimes completely out of the blue, having dinner, and the next thing you know, they're hyperventilating, nauseated, sweating, have palpitations, are physically extremely uncomfortable. It's dramatic, and it gets parents' attention because it's sort of frightening, and people think it's asthma or, something terrible is happening to their child. And we see a lot of that in teenagers, and we can't always get to the bottom of it. It's highly heritable. And we'll talk a little bit about that later. Let's just move on to the second list. Selective mutism is generally describes a child who's very happy to talk at home in the total comfort of their family, but once they leave the house, either to go to school, go to the doctor's office, go anywhere else, they can't talk. They're too anxious to speak. And I have a number of these kids in my practice right now, and it's really fascinating the degree to which, no matter how hard I work to make them feel comfortable, they can't really spit it out. And I think it's very important for parents to recognize that that's not a behavior problem, it's an anxiety disorder. And I think that that's part of our role as pediatricians, is to make sure that people understand that when their kids are doing some of these things that seem like, oh, he's just oppositional or doesn't want to cooperate with me, that anxiety is driving it. OCD is not uncommon in this population. It's quite common in kids on the spectrum. I have some kids that have both ADHD and OCD, and basically the important distinction here is a difference between obsessions and compulsions. So obsessions are thoughts that you kind of can't get rid of, and compulsions are you're compelled to do something. Wash your hands, line up your shoes, touch every surface in the room. Whatever the compulsion is, it causes a lot of distress if you can't do it. Post-traumatic stress disorder is usually a feeling of anxiety or panic that is triggered by a past experience. That could be any number of things that the child experienced as traumatic, whether or not we would believe it was a traumatic thing. If the child, say, for example, a child has terrible separation anxiety and got lost in a shopping mall, which, happened to one of my boys, that child could experience that as much greater stress than a typical child who, like, once he's connected with his parents, is totally fine. And agoraphobia is kids who are afraid of a particular environment. So some people would call, the elevator thing an agoraphobia. They're in a mall, or they're at a baseball game, or they're at an event with their family, and suddenly they can't tolerate how they feel in that situation, and they need to go. So these are sort of the categories that we think about when we think about anxiety, and probably the most common is the generalized anxiety, but there's just a lot of it in childhood. Perri, do you want to take the next couple of slides?
So anxiety, as Eileen said, it's not only common in childhood, it's also very, very common in adults. And I think one parenthetical comment before we talk about how common it is in children is to remember that, and adults will have experienced this, many people respond by saying, of course, everybody's anxious. Of course, performing makes you anxious. Of course, social situations make you anxious. We're all like that. And one of the things that I think comes up for both children and adults in this situation is people don't understand how big a problem this is, how much it is getting in the way, how much it's preventing them from doing what they need to do, because the word anxious is used not only for people with the anxiety disorder, but also for something like separation anxiety, which is a normal part of being a small child and learning to say goodbye to your mommy and your daddy at daycare. But the anxiety disorders, it's the most common mental health condition that comes on in childhood. And, you've got numbers here of 25 to 32%. And the adults, as Eileen said earlier, tend to report that the symptoms started in childhood. It's unlike many of the conditions we talk about, it's more common in girls than it is in boys. 2 or 3 times as common in girls. It may show up at any age, and it tends to persist. But again, as we said earlier, although the anxiety tends to be an ongoing issue in people's lives, the specific type of anxiety and the way it shows up may vary over time. And you'll see here described something called the pediatric anxiety triad, which includes 3 different sort of triggers for anxiety: that generalized worry, the generalized anxiety, the social anxiety, and the separation anxiety. And it is associated with a number of other conditions, as we've already said, with the attentional conditions, with ADHD and ADD, but also with this other range of mental health conditions, differences that children may be growing up with and living with.
It might be worth just defining what a somatoform disorder is. Anxious kids are more likely to worry about physical symptoms. They notice a freckle and they think it's skin cancer, or they are prone to catastrophic thinking about typical physical symptoms. And we see a lot of that, especially in teenagers, if they haven't sort of developed an appreciation for what it means to be an anxious person, which many of us are. They overuse the doctor in the emergency room because they think every physical symptom is potentially something catastrophic.
Go ahead, Perri. I was going to say that's also connected to, or worth thinking about, are kids for whom anxiety manifests itself in physical symptoms like headaches, stomach aches, and that's how they signal themselves or process or respond to their anxiety.
I can't remember if we have a mention of substance use disorders in a later slide, but I think it's just worth mentioning that untreated ADHD and untreated anxiety will often lead a child to find relief somewhere. So if they have parents who don't understand that this is anxious, or teachers that are yelling at them all the time because their anxiety is out of control and it's causing them to have difficulties with behavior or concentration. I also, one of my other clinical interests is the care of children whose parents have substance use disorders, and I hear a lot from parents when I ask them, like, how do you think you went down this road? They'll describe being very misunderstood as children, and not having a language to talk about their anxiety or their learning differences, and that that's how they got relief from their symptoms. So I think those of you that are listening to this webinar are much less likely to have kids that go down that road. But I think it's worth mentioning that it's so important to address these things and help a child develop a coping strategy so they don't look for other ways to cope. So the next slide is about the prevalence of specific types of anxiety disorders. And as you can see, these are not small numbers. 9% of kids with social phobia, specific phobias in younger kids who are afraid of dogs or afraid of people in Halloween costumes, or whatever it is. These are not small numbers. When you think about, putting this next to kids with asthma or diabetes or whatever, these are large numbers. And the one that we see that's more common in boys than in girls is actually OCD. So I think, all of these things are not infrequent when you look at them from a pediatric perspective or from the perspective of being a parent. I'll take this slide, Perri, and you can take the next one, okay?
Okay.
So people will often ask me, like, why is she anxious, or what causes anxiety? Is it genetic? And so we have not, I shouldn't say we because I'm not a researcher, but genes have not been identified that are known to be related to anxiety disorders. But anxiety is definitely considered heritable. So it definitely runs in families. And probably one day there will be a gene that's identified, but that has not happened yet. If a child has a first-degree relative, a parent or sibling, or even a grandparent with anxiety, she or he is more likely to have anxiety themselves. If we model anxious behaviors for our kids, they will pick up on that feeling of anxiety in parents, and I think that can start, as soon as they're born, in which every parent is anxious when a baby is born. I mean, we're all anxious, even if we didn't have an anxious bone in our body before. Having a baby will make you anxious, but there are degrees of anxiety, and some of it is functional anxiety. Making sure they're sleeping on their back, or making sure they're not eating too little or not enough or too much. But there is also sort of over-the-top anxiety, which I think people can transmit to their babies. It's really important to help the child recognize that this is something that they are struggling with. You could say, for example, this runs in our family. I have this too, and here are the things that I do. This is why I go see my therapist, or this is why I do yoga or mindfulness or CBT, whatever it is, because so it normalizes it in a family. There is some data that parents that are extremely critical of their children or controlling can increase anxiety in kids that are already there. I'm thinking of a grandmother I saw recently with her two young grandchildren, and she's raising them, and she's very rigid and very severe and very harsh in her parenting style. And her kids are anxious. These children are anxious because I think they're so worried that they're going to do something wrong. A new onset of anxiety in a child who was not previously anxious always makes us think, what's going on in this child's world? Did something happen at school? Did something happen in the family? Did somebody recently die? And so I think that's more important for teachers to recognize than parents, because parents would know. But sometimes kids can have unexpected reactions to things that wouldn't strike us as particularly traumatic, but they experience it as traumatic.
And I think that can even happen in the classroom. I've had patients who responded to a lesson in history that told a story about war, or a science class that talked about climate change, and every other student in the class took it as a regular school lesson, a regular day, and then this one child took it as something much more personal and much more anxiety-provoking.
Okay, Perri, you want to take the next slide?
Yeah. So One of the things that I bet everybody who is listening knows is that the way children express an anxiety is not necessarily going to be completely straightforward. The child is not going to necessarily come and say, I'm anxious about this and I'm worrying about it. The child may not even necessarily understand the connections. The child probably or very well may not realize that this is an extreme overreaction to the anxiety. It may seem natural. It's very common for it to manifest as physical complaints. As when I think about going to school, I get terrible abdominal pain, or I get a bad headache, or when I was going to go out and see my friends, I get a terrible headache. And I think it's really important to emphasize that that headache is real, that stomach ache is real for these are children who that's where the anxiety goes, that's the way it manifests. Some of the other things that kids may look like when they're anxious, they can look angry, they can look irritable, they can look sad, they can look like they're being oppositional and difficult. They can be refusing to go to school, or refusing to go on the long-planned trip, or refusing to go see their friends. They can have trouble sleeping. They can be eating too much because they're anxious, or they can not be eating at all because they're anxious. It's getting in the way of their ability to do what they need to do, and in most cases want to do, both at home and in school and on the playground. And as Eileen said earlier, children who already feel different, separate, children who are already aware that what's easy for their classmates is more difficult for them because they have learning differences, because they have attentional issues, are already worried about what goes on at home, what goes on at school, what goes on the playground. They know things are harder for them, and this is associated with increased rates of anxiety.
A question that we get asked a lot is, what comes first, the anxiety or the ADHD? And it's a great question, and we don't know the answer to it. We just know that these things are associated with each other, and it's very, very difficult to tease it out. Between us, Perri and I have like 60 years of pediatric primary care experience, and we still haven't figured it out. But, I can tell you anecdotally, my experience is that often, even in very young children, 2 or 3 or 4, you can see symptoms of both anxiety and in kids who are, are sort of really active in the exam room, jumping off the table, can't sit still, have a million questions. Like, if you line up a bunch of 3-year-olds, there's quite a range over the course of a day or a week, in my experience with seeing the kids who are entirely comfortable sort of sitting still, letting their parents have an adult conversation, and the kids who are like glued to their mothers because they're so anxious I might touch them, and the child who is sort of all over the room. And so I think some of these things are manifested very, very early in life. And increasingly, we're seeing kids diagnosed with anxiety as young as age 3. The word comorbidity, which is probably something that's somewhat familiar to at least some of you, is conditions that occur at the same time. So, a child has ADHD with attendant anxiety, or has anxiety with attendant ADHD. It's really important. And I know that not everybody has access to high-quality specialists, but it really is important to have at least a couple of visits with a well-trained developmental pediatrician or child psychiatrist or child neurologist or PhD psychologist who is expert at helping tease these things out over time. It is worth mentioning that although we did talk about kids somaticizing and coming to us with physical symptoms, that anxiety can be a symptom of something real. And so I have seen all of these things, hyperthyroidism, in an otherwise typical child who started behaving, wildly kind of ADHD-like, extremely anxious, came in, and it was evident just looking at her that, her teacher sent a note saying, I want this child on Ritalin. And in fact, she was in thyroid storm. Her thyroid had gone haywire, and it was making her act in a way that was not typical for her. Migraines, which can occur in childhood, often, we see a lot of kids in the sort of 8 to 9-year-old age group that present with migraines. And, instead of the anxiety causing the headache is causing the anxiety because they're very severe and they're frightening. And also kids who metabolically are prone to have a low blood sugar will also make you feel bad in a way that can create a lot of anxiety. I think I'm sorry, go ahead, Perri.
No, go ahead.
I was just going to do this slide about, knowing whether a child has ADD or ADHD. The symptoms have to be present early in life, like creating difficulty early in life, early childhood or early elementary school, in order for it to be considered a real diagnosis. In addition, it doesn't suddenly present at age 12. You don't suddenly present with ADHD at age 12. The caveat to that is kids who have ADD without the H often fly under the radar. And so I definitely do have a number of mostly girls, not exclusively, but mostly girls who, as they get a little older, start struggling as the academic demands increase when they didn't really struggle before, and end up with a diagnosis of ADD because they really can't focus, but they're not drawing attention to themselves by constantly dropping their pencil or needing to get up and go to the bathroom, or, they're not drawing attention to themselves. It's much more challenging to make that diagnosis than it is to make the ADHD diagnosis. A lot of kids will develop poor self-esteem related to the social skills and academic underachievement that comes with the symptoms of ADD or ADHD, and it's hard to have these things. It's hard on kids, and it's hard on their families. And I think that, you have to have we in our profession have to have a lot of compassion for these kids and their families, because it doesn't feel good to have ADHD. It's, it's kind of ego dystonic is an expression that we use in medicine. Like, it stinks. And, helping the child understand that it's not their fault and that lots of other kids have this too, and we're going to help you. An important component of an ADHD diagnosis is that the symptoms occur not just at school or just at home, but in both environments or any other environment, on the baseball team or in the after-school program, that they are sort of uniform across different environments. If the child is only having these issues at school, it's much more likely to be, a bad fit with the teacher or with some aspect of the environment in the class. There on the slide is a list of common associated conditions, and as you can see, a good number of kids with ADHD will also struggle with learning disorders, the most common of which is written expression. Oppositional defiant disorder, ODD, it's a diagnosis that we definitely see. I, as a pediatrician, have a little bit of trouble with it because it sounds very judgmental to me. But we've all seen it, and I have often wondered if it's, the child's anxiety that's making them so oppositional that they can't understand their own feelings. Something's making them anxious. They're not going to cooperate, and not only that, but they're going to give you a hard time. Anxiety disorders we've already discussed. You will see kids with other developmental delays. If you look retrospectively, oh yeah, wow, that kid was actually speech delayed or had some, motor delays, didn't walk till he was 18 months, and some difficulties in social development. The mood disorders, 1 in 10 is a pretty high number, and it's, again, not terribly unexpected in a child who, struggles being understood and having friends, because, one of the hallmarks of ADHD is if you're not under control with your ADHD, other kids don't like you. It's hard to be liked because you take up a disproportionate amount of the adult attention in the room. Tic disorders are more common. It's complicated by the fact that the kids are more prone to tics to begin with, and that often the underlying tic will be uncovered when a child is started on a stimulant. And so, there's always the question, well, did the stimulant cause it, or was it just there waiting to be uncovered? I kind of fall in the camp that it was waiting to be uncovered because it's so common, but it does, create a lot of pause for parents when that happens. And then the PTSD, I think, kids as they get older, sometimes they'll do impulsive things that will create a traumatic experience for them. And then in addition to their ADHD, they have a traumatic response that they need to learn to cope with as well. Okay. Perri, you want to take the next couple of slides?
Well, or at least this first one, but break in if you want to add.
Okay,
so,
you bet.
The place that probably we've all been wanting to get to is the question of how can we help? What can we do for kids who are struggling with this? And first of all, when do we actually think that a child's anxiety is going to require something more than just a little bit of discussion with the parent? And that's going to be a question of whether it's really getting in the child's way, whether it's preventing the child from functioning, from enjoying himself or herself, from getting along in daily activities. And whether or not children have ADHD, whether they have learning differences, the treatment for anxiety is going to be the same strategies for children of these given ages. One way or the other, it's going to really involve a lot of help and involvement by parents, and it's going to start with both the parent and child learning about anxiety and how it works and developing a language around what it feels like and strategies to deal with it. The biggest pitfall here for parents, and this is for loving, caring, helpful parents, is that the initial response to a child regularly encountering some kind of situation that provokes anxiety is for parents to protect the child, to avoid the situation. And that's everything from, we won't take any airplane flights to, I can see there's a dog coming and we're going to cross the street, to establishing incredibly elaborate and lengthy ways around separation. That's what almost every parent's first response to any kind of specific anxiety-provoking situation for a child. And it's, interestingly, not the way that the treatments work and not the way to help children out of it. But it's really easy to fall into.
That's for sure. Having done it myself. I mean, all of us do it to some degree, right? Like, yeah, it's a natural thing for parents to want to protect their kids. I'm thinking of a story from our book, Perri, about a mom whose daughter was kind of extremely anxious about what we would consider sort of typical experiences in day-to-day life. So the doorbell, she couldn't stand the sound of the doorbell. The coffee grinder, the vacuum cleaner, like she just would go crazy. And so the mom realized that she had made all of these adjustments, like disconnected the doorbell and put on a knocker, bought her coffee ground, had somebody else come in to vacuum when she was out of the house, and that she had sort of adjusted her life without even realizing it in a way that, in the long run is not going to work because people have doorbells and coffee grinders. And, helping the child learn to cope over time is probably the right thing to do. Okay, so I think helping the child, a worrying child, depends on how severe the symptoms are. And so there's a lot of mild anxiety out there, and I think just getting some counseling or therapy, educating the child and yourselves about what it means, what an anxiety symptom is, encouraging brave behaviors or coping strategies instead of just avoidance strategies. Some people have very successfully used journals or diaries to keep track of symptoms and helping their kids understand the degree between mild, moderate, and severe anxiety. Social stories is, we're borrowing that from the autism literature for kids who have a lot of social anxiety. Social stories are when you script something out for your child. So, for example, we're going to a birthday party. There are going to be a lot of people there. It'll be really noisy, and there will be balloons, and some of those balloons will probably pop and make a really big sound. Here's what I want you to know. So sort of kind of scripting it out as you're driving to the birthday party or the night before it to explain, oh, the last time you went to a birthday party, you had a really hard time, but I know you really want to go, so we're going to just talk about this in advance. Some people will use things like a dream catcher or a worry box or something to like try to contain the worries, some visual aid to say, all right, we're putting that in the box. It could be even in your mind's eye. We're going to put that in the box and not worry about it. If kids have, more moderate symptoms that are really impairing their ability to function or go to school or ride an escalator, CBT is really the gold standard. Cognitive behavioral therapy is the gold standard treatment, and that therapy is described as exposure response therapy. It requires parents really being on board with the child. There's often a workbook involved with homework. This week you're going to do X, Y, and Z, and then you're going to come back and you're going to talk to me about it. The child with the elevator phobia is going to see our CBT therapist here, and she's going to talk to him about what are your symptoms when this happens, what do you think is going to happen, and then do you think you could go just one floor instead of 6? And just to expose him to a little bit of the thing that he's anxious about, and then sort of talk him through like, well, that wasn't so bad, was it? I'll bet you could do too, over time. For kids that are more severely impaired with their anxiety, and sometimes kids with OCD can be really paralyzed by their OCD, a multi-pronged approach that involves therapy with the family, individual therapy for the child, along with CBT and often medications. And we're not going to spend a ton of time talking about meds because it's so individualized for each child. But the way that I explain it to parents, and I say the same things when people are asking me to think with them about whether they want to start a child on meds for ADHD. If the child is really suffering and the people in their environment are really suffering and the child is not moving forward and other modalities have not been effective enough, meds can help a lot of kids. And, the way I think about it is meds can turn down the volume on the symptoms to a degree that makes the child able to access the other strategies that we're trying to put in place to help them. Sometimes the anxiety is so profound that all of these other strategies, they can't attend to them because they're so anxious. So sometimes turning down the volume on the sort of physical sensation of anxiety makes it easier for kids to access the therapies that we're trying to devote to them to help them. And the other thing I'll say about meds is that no decision is cast in stone, and these meds are pretty safe, and we're going to talk a little bit more about that later. The next couple of slides are just the next slide, is just an example of kind of some visual aids that people use, like feelings thermometers, or the coping cat is another one, to sort of help kids say, oh, well, actually, I don't feel so bad right now at all, or I'm starting to get a little anxious, but it's okay because it's motivating me to do my homework, or I can't cope. And sometimes giving a child a visual aid like this, I think for all of us, you look at this and you can point out where you are right now on this scale, because I think all of us, well, it's rare for even functional adults to not have some degree of anxiety. So of the different types of therapy, CBT I talked a little bit about, but it has the strongest evidence base, which in and of itself is kind of dramatic because doctors love to talk about, is it evidence-based, meaning has it been studied and does it work? And CBT has the strongest evidence base for any psychotherapeutic intervention ever for anything. And so that in and of itself, I think, is really remarkable. We are just about to embark in our hospital on a big study of in-person, one-on-one cognitive behavioral therapy versus web-based CBT. There's a program that we're going to study. So some kids will be randomized to come in and get the intervention in person and some on the web, because we know that they're both effective, but they've never been studied sort of head-to-head. But for people who live in rural areas or remote areas or places where an in-person CBT therapist is not available, and I can tell you even living in a city like Boston, it's not always easy to find someone, it can be very, very helpful. It's not about your feelings, like it's not psychodynamic therapy. It's not like, oh, tell me about your childhood. It's very behaviorally oriented. It's time limited. It's goal directed. We are focusing. Our target symptom is your anxiety in elevators or your social anxiety. And so kids are trained, like cognitively trained to react differently to their situations that provoke their anxiety. I already described a little bit of the exposure response concept, and Coping Cat is an example of one of these programs, and I have a slide about that next. Whenever parents are involved in helping kids manage their anxiety, whatever age, whatever severity, it's been associated with improved outcomes for kids. Very young children are not going to be able to engage in CBT, or kids with developmental delays who might not have the language capacity, and generally people will do play therapy with those kids to at least understand what it is that's making them anxious. And then groups for older kids or kids that have a lot of social anxiety or phobias. Sometimes if they're around other kids with a skilled therapist, it's helpful for them to see other kids going through the same thing, like it is for all of us. These are just a couple of programs. I think Coping Cat is actually a web-based program, but again, like sort of programs that you can use to help you develop a language with your child and strategies for success. I can see that we're getting short on time, so I'm going to quickly go through this slide about meds. Generally, the SSRIs, the selective serotonin reuptake inhibitors like Prozac, are considered the first-line therapies. It's slow to take effect, and people often lose patience. They'll say, oh, it's been 4 weeks and nothing has happened. And so it's really important. These meds are not like antibiotics for strep throat. It takes time to titrate to get their effective dose, and then it will take time for that effective dose to kick in. And, I usually will say, let's try this maybe for a year, maybe for 9 months, maybe for the school year, and if things are going well, we can take a break. It's always worth mentioning the black box warning, which came out in 2004 about the SSRIs, showing a small increased risk of suicidal ideation and behavior in kids with depression. We don't know if that is true for kids with anxiety. But if it's going to happen, it usually happens early in the game. And I always use the start low and go slow adage, that start at the lowest possible dose to make sure you're not seeing a side effect, because that side effect is not dose related, and then increase the dose as necessary very slowly. The evidence shows that CBT and medications are equally effective, but if you use them together, the effectiveness is superior to either one of them alone, which I think is important. There are, a lot of people ask questions about, well, my child's already on meds for ADHD. Do I want to add another med? And I think this is a really difficult area for parents to think about the polypharmacy idea. A lot of parents don't like that. I understand completely, but this is a place where you need a highly trained specialist to weigh in on, is there a medicine that can target both? Is there, can we wean off one and start another, or do we really think that a combined effect of more than one medicine is worth it? Finally, I think, the school environment is a huge part of life for most of our kids, unless we're homeschooling them. They spend many hours of the day there. Many kids will require an IEP or a 504 plan, but I think that we have to pay really close attention to making sure that we're not promoting avoidance strategies, that we're actually engaging in trying to help the child cope with typical experiences of being in school. And I put the last thing I put on this slide is no punitive responses, because kids should not be punished or not allowed to go to recess because they're anxious. If anxiety is what is contributing to their oppositional behavior, keeping them in from recess is the last thing that child needs. So finally, I want to wrap up so we have a little time for questions. Anxiety is quite common and in certain situations can be useful. There's such a thing as good anxiety. If it's clinical, clinical anxiety depends on a child being impaired in areas where we would expect them to be able to function. It may present differently in childhood than it does in adults. It can change over time. We did address the mood disorders and substance use, and a child with baseline anxiety or no anxiety who has sudden worsening of their symptoms may indicate some trauma in their lives, and that parent involvement or guardian involvement, who's ever living with the child, will improve outcomes of the therapies. So I think I have some references, but I think we should stop there and see how many questions we can take.
Thank you both. That was a really great summary of anxiety in there, as you can imagine, a large number of questions. I wanted to start with cognitive behavior therapy, because that is, as you said, the gold standard. And I guess two questions. You mentioned web-based cognitive behavior therapy, and I'm guessing that, as you suggested, it's difficult for many of our listeners to find a good cognitive behavior therapist.
Yep.
Are there specific web-based cognitive behavior programs that you have seen to be effective in your practices?
I am going to turf that question to one of our child and adolescent psychiatrists, and I promise to get back to you, because there are a number of them, but I would really like to hear from a child and adolescent psychiatrist, like, which ones do you recommend? Which ones have you used? I mean, we're using one in this head-to-head study that was actually based in Australia, where they have some pretty strong data. But I will get to the bottom of that, and I will I will get that answer to you, because it's a great question.
That would be wonderful, because it is something that comes up frequently at Attitude, and we really don't have a good answer. And we're aware of the large number of programs out there, many of which are quite expensive. And everyone is sort of wondering, where do I go with this? So I'm gonna. There's a lot of questions. I'm gonna pose some of the specific ones, behavioral, because they may be helpful to people. And listening to your thoughts. This is a person whose daughter does not want to try anything new. She's terrified and anxious about any new experience, and her mother is asking, How do I help her to have new experiences? What is it? She says, what is a good boundary? How does the mother address a child who's afraid of trying anything new?
Well, since I don't know the child, and I don't know what exactly she's afraid of, but sometimes just in general, doing the social story scripting out of things. Sometimes
that was really interesting, scripting.
Yeah, not if they don't know what to expect, and there are certain things that they should be able to expect, and that, like, okay, so like I used the birthday party example. Okay, so what, how will you feel if a balloon bursts? Will it scare you? Will you cry? Like, let's just talk. Let's just talk about it. I'll try to be right next to you, but this is very likely to happen, and I want you to be able to go to this party. Like, sort of scripting things out, and sometimes just incremental, like, I won't leave the house. So to even go to the birthday party, like, okay, we're not going to go to the birthday party, but we are leaving the house. We're going to sit on the front porch and read a book.
Mm-hmm.
We're going to take a chair out to the sidewalk, and we're going to sit there. I'm sorry. I have seen these kinds of things in families where, it's almost like when you're sleep training a child, the sort of like inch by inch across the room, like, okay, you can't do this, but you can do this. And then maybe next week you can do that. And I think like that, a child who is so afraid to try anything new probably would respond to CBT. Probably would, get some help from a cognitive behavioral therapist.
Can you describe a bit about how cognitive behavior therapists work to address for example, that kind of fear or another kind of anxiety? Just give a sort of classic example.
Do you know how old the child in question is?
No, I don't.
No. So, okay. So a lot of it depends on the age of the child, but I think, but let's just assume that it's a 10-year-old, and that she's getting, she's getting paralyzed by her anxiety to a degree that she doesn't want to go out of the house. And so a CBT person would, first of all, sort of take an inventory of the symptoms, like what are the symptoms? What are your physical symptoms and your emotional symptoms of distress in anxiety-producing situations? And what are the things that make you anxious? And then let's just chip away at that. And they will actually give you homework and exercises to do between one session and the next. So, and it might be something as simple as, okay, this is a child who won't leave the house. We're going to sit on the front porch for 15 minutes and just talk or read a book together. And then we're going to maybe sit in the driveway, or that, like sort of inch by inch. And was that okay? Were you overwhelmed with anxiety? Oh, not really. That's great. I'll bet you could do this. So it's very like prescriptive, inch by inch homework exercises. And, a lot of kids really do move forward with anxiety symptoms. I've been overwhelmed by the degree to which some kids can come in and say, my life is really different than it was a year ago. It's very uplifting.
There's a very practical focus on strategies. So if you start to feel the way that you sometimes feel, what are you going to do? And people use a wide range of strategies. There's not one particular all-purpose, all kids should do this, but some therapists work on sort of mind-body strategies just in terms of, what can you do, you individual child, to calm yourself down. And for many children, it's tremendously reassuring to have a strategy or two strategies or three strategies in your pocket, and just to be able to say, if I start to feel this way, here's what I'm going to do.
Okay. That sounds, that's very clear. Thank you. Another very specific, this will be the last of the two specific questions from someone that I think is illustrative of a kind of anxiety is, this is a person whose son's anxiety is associated with losing anything from a big sports event to a board game. And she says it's a child who normally expresses his emotions very well. But when he loses, he becomes completely irrational. Everyone has cheated. The refs are all bad. The world is against him. He's unable to access any of his coping skills. And it's very hard for his parents not to become angry with his behavior. Yeah. And she's actually asking about coping skills as a parent, which I think is also how to handle the child anxiety, I guess. Yeah. And it's an interesting question because it links anxiety to behavior, which is something that, as you discussed, it's often seen as, anxiety is often interpreted as oppositional behavior or bad behavior.
Right, or just being obnoxious, right? And,
yes, right.
And so, I have seen a child like that, a very smart, high-functioning child who's now, an adult in law school. But he was one of those kids who could not tolerate failure of any kind. Very similar, could not play team sports because he could never be on the losing team. Board games, anything. And his family really did adjust their life to make sure that he was never in a competitive situation in which he would lose. And like that's really difficult. Everything was a cooperative game. Like all his birthday parties were like, we're on a hunt to find these things. Nobody's going to win. Nobody's going to lose. But that really is adjusting life in a way that is not really typical, because we all are going to experience loss and failure in one way or another. And I think I would guess that is anxiety, and that a real intervention to help him understand that it doesn't make you, that it doesn't need to make you so anxious to lose, because we all lose. None of us likes to lose, but all of us lose some of the time,
right.
Even the Red Sox.
Okay. This is a parent who says, I would love to know how to respond to physical symptom complaints. Literally, what do I say when my child says she has a stomach ache or a headache, and I know that this is anxiety-based?
Mm-hmm.
As I think I said earlier, it's really important to remember that that is not the same as saying there isn't actually a stomach ache. There probably is a stomach ache, and the stomach ache can be very uncomfortable. And actually, the people who work on what we call functional abdominal pain in children, functional abdominal pain in children means the child has recurring abdominal pain, and we can't find anything that's causing it. We've, gone looking for the whole long list of gastrointestinal problems, and none of them are there. But the pain is real. The people who work on it will say that they're very jealous of the headache people, because if anxiety and tension gives you a headache, nobody thinks, oh, it's not really a headache. We as adults are all familiar with the idea that you may understand that your headache is connected to anxiety, but you also understand that your head really hurts and that you can't think about anything. So anyway, I think you start by understanding that the pain is real, that the pain is there, but that in order to cope with that pain, again, the child is probably going to need a set of strategies which recognize that it's rooted in anxiety. And again, many of the people who work on this, especially on the abdominal pain, use a lot of mind-body kind of visualization, relaxation strategies, and they say that in many ways children are better at this than adults if you can sort of, again, teach them very specific things. And you need to teach those strategies without suggesting, actually, there's nothing really wrong with you, therefore we're going to do a visualization exercise. It's recognizing that the child is in distress and that these strategies may help.
Okay, interesting. All right. I am afraid that we are out of time. I want to thank you both so much for such an excellent presentation, and remind the listeners of Dr. Costello and Dr. Klass's book, Quirky Kids, and to look for a new edition coming out soon. I'd also like to tell you about the next two webinars from Attitude on ADHD experts. Next week, we have Dr. Thomas Brown on optimizing stimulant treatment. And on Tuesday, July 30th, Sharon Saline on building executive function skills in your child with ADHD. I'd also like all of you to invite all of you to subscribe to Attitude Magazine. I think you'd enjoy it and find it useful. You'll find a link on our website if you click on the cover in the header. And so the best way to support Attitude is subscribe. Thanks, everybody. Have a great rest of the week and a great summer weekend. Thanks for joining us today, and thank you so much to our two speakers.
Thank you.
Thank you.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.